It gives me great privilege and pleasure to introduce our dean again, to introduce someone else, Dr. Joe Schnurr, a classmate of mine, which I'm very pleased to say, and in regard to our Heggie lecture.
Thank you, Brian. It's really my pleasure to introduce this lecture in integrative medicine. This is the 6th annual Betty Ann and Wade Heggie lecture on functional medicine. Joel introduced the topic of his talk when he gets to it. First off, though, I'd like to acknowledge that the Heggie family for the sponsoring of this lectureship. In 2005, the University of Saskatchewan approved the establishment of the Betty Ann and Wade Heggie Lectureship in Integrative Medicine. As part of the establishment of that award, it's said to support the cost of the lecture and or other delivery methods to provide continuing education opportunities for faculty, residents, and practitioners in the field of complementary and alternative medicine. Excuse me. This lectureship, which will exist in perpetuity, will provide resources to help bring high-profile, knowledgeable, and experienced physicians to the College of Medicine to address current topics in complementary and integrative medicine. Integrative medicine, for most of you, I think you understand, is the practice of medicine which reaffirms the importance of the relationship between the practitioner and the patient, focuses on the whole person, is informed by evidence, and makes use of all appropriate therapeutic approaches, healthcare professionals, and disciplines to achieve optimal health and healing. Integrative medicine is now being taught in virtually every medical school in North America. The 2005, the Center for Integrative Medicine received formal approval from the University Council for designation as an interdisciplinary academic center at the University of Saskatchewan. And I think we could thank our previous Dean, Albritton, for really putting the strength, the resources, and the commitment to get that happen. I've also supported this group, and I worked with Joe and Michael to get a very novel integrative approach to evidence-based complementary medicine teaching in an undergraduate program, and it's been very, very successful over the last 8 or 9 years. To continue on the lectureship itself, Betty Ann and Wade Heggie have been both prominent members of the business, volunteer, and therapeutic and the philanthropic communities in the province for many years. They're both here. I met them. And maybe you'd like to stand, maybe not. Wade has been involved in aviation, life insurance, and financial planning, and has held prominent volunteer roles with several community-based organizations and plays a mean round of golf, I guess. That's what my words say. I haven't played against you, but I believe the words. Betty Ann has had an illustrious career as a senior executive in corporate relationships in the potash industry and has held many numerous directorships in the public and the private sector. The Heggies have been wonderful supporters of the University of Saskatchewan and have recently taken a leadership role in shaping the future of the university through their participation in the Thinking of Our World of Our Future campaign. They have provided tremendous volunteer assistance in attracting other donors to the U of S over the past several years. Wade and Betty Ann have both had extensive personal experiences at leading integrative health centers throughout North America. This lectureship is a way that they have chosen to articulate this vision for integrative medicine in this province with their own gift to the College of Medicine, and for which we thank you. So I would like to introduce our esteemed speaker, alumnus of the college, as Brian has indicated, for this 6th annual Heggie Lecture in Integrative Medicine, Dr. Joe Schnurr. I'm sorry, Joe. Joe has practiced family medicine for over 25 years in Saskatoon, with the last 15 years focused on integrative and functional medicine approach to the prevention and the treatment of chronic illness. He's trained in medical acupuncture, medical anthropology, and functional medicine, a science-based, personalized medicine that deals with primary prevention and underground causes of chronic disease. He was co-founder of the medical director of the Center of Integrative Medicine, which I talked about earlier in the College of Medicine with Michael Epstein at the University of Saskatchewan. In April 2012, he joined the Inspire Health, Canada's foremost integrative cancer care center, and is lead physician at the Inspire Health Southern Interior Center located in Kelowna. So we were unhappy to see him leave. He and Michael and many other active people were critical in doing this. And to my mind, when this was brought on, there was a lot of resistance to integrative medicine, to complementary medicine in the college, and a lot of resistance for teaching it in our undergraduate program. And what they added with the other faculty committed to this was an evidence-based approach. And I think over the years they convinced everybody that this is a formidable and real way to treat patients with chronic illness. So Joe, come on up. You have established yourself with us, and thank you for all your work.
Well, I'd like to thank Dr. Coulter for your kind words of introduction, and to Betty Ann and Wade for your ongoing sponsorship of this seminar. And I'd like to give a warm welcome to all of you who have come out here this morning. I see lots of familiar faces, and I'm happy you could join us. So trying to talk about comprehensive strategies to addressing root causes of chronic illness in 45 minutes or less is a little bit more than a trifle daunting. What I am hoping in this period of time, though, is to leave you maybe with an updated framework or roadmap for helping us navigate through this maze of this epidemic of chronic illness. So I'll just briefly, learning objectives, we'll talk about a whole systems approach to chronic illness and why it's needed. We'll talk about some emerging concepts in chronic illness. And then a little bit about functional medicine and how that can play a role in this. So when I said the word epidemic of chronic illness, I probably, in fact, should have used the word tsunami of chronic illness, because I think this better captures what it is that we're facing. And just like a tsunami, it often captures us with devastating consequences and often very much unaware, just like these vehicles and drive along here. And this is not just something that we as healthcare providers have to deal with as well too, is it affects society. So this is something that every person has to be involved in terms of addressing these root causes of chronic illness. And so we know that over 9 million Canadians already have at least one or more chronic illnesses, and this number is growing. And will continue to grow as the population ages and as the risk factors for these chronic conditions increase as well too. And while the statistics are a little bit old, saying that at least 50% of physician visits are for patients who have one or more chronic illnesses. I've seen some stats now saying even up as much as 85%. And certainly those with the one or more chronic illnesses are forming the majority of people who are patients in hospital. So the economic burden, needless to say, is really substantial. And again, these are a little bit older stats from 2005 in terms of chronic illnesses in youth and adult population in Canada. And it's also only looking at 7 chronic illnesses, of which we know there are many, many more than that. And so even what we're seeing here, though, with the older data, in this age range of 40 to 59, we're seeing that already more than a third of individuals have at least one or more chronic illnesses. When you get to that 60 to 79, that number now increases to more than 2/3. So again, we're talking, huge percentage of the population. The Milken Institute, which is a nonprofit, nonpartisan economic think tank based in the US, had put some numbers to this and looked at came up with a number of over $1 trillion annually being spent on healthcare, and that this amount can balloon and will likely balloon to more than $6 trillion by the middle of the century. Other stats that I've recently read is pegging that as possibly as much as $16 trillion. Again, these are phenomenal amounts of money. And much of this economic cost can be avoided through more effective prevention and treatment. And their conclusion, which I want to read, incentives in healthcare systems should promote prevention and early intervention. Employers, insurers, governments, and communities need to work together in developing strong incentives for patients and healthcare providers to prevent and treat chronic disease effectively. And so again, I think the important message here, and I'm going to bring that up time and again, is that this isn't just a call for physicians to change the way we're practicing medicine, but this is a call for insurance industries, a call for communities, for neighbors, for patients, for everyone involved. We look at the incidence of diabetes in Canada, and we see that by the year 2020, there's going to be a sharp increase in the people diagnosed with diabetes and a sharp increase in the costs of looking after those with diabetes, both direct and indirect. And we look at some other common chronic illnesses, and this is US data, but again, probably very similar to what we'd see comparatively in Canada. But men already have almost a 1 in 2 lifetime risk of developing cancer. And for women, that's more than 1 in 3 lifetime risk. Again, just the burden of this disease and the devastating consequences of the disease for individuals is phenomenal, and their loved ones. But also the economic impact is going to be huge and growing. And while the death rate from heart disease is less since 1950, the incidence of heart disease hasn't decreased since the 1970s. So we're better at keeping people alive or after their heart attack or heart failure, but we're not any better at preventing them from getting heart disease in the first place. And so now we're having this bottleneck of increasing numbers of people with chronic cardiac conditions. And again, the economic costs of just these two alone is also staggering. So it does speak to some of the limitations of our conventional approach. Other evidence of some of the inadequacies are looking at this burgeoning number of people with obesity and consequently also with diabetes. And we're also seeing increases in many other health conditions, in autoimmune and inflammatory conditions and digestive disorders and respiratory disorders and on and on. So why are we seeing this chronic disease crisis? Well, it's for two reasons. One is that we're trying to address this tsunami of chronic illness with our 20th century delivery model. And two is that our focus is on the downstream drivers or downstream consequences of the upstream drivers of chronic illness. So in an acute care situation, patient's story is squeezed down to the chief complaint and history of present illness, and the diagnosis becomes of main importance. And so if we have an example here, somebody presenting, say, to emergency with wheezing, and we're taking their history of present illness. They may have sudden onset, a tightness in their chest, a shortness of breath, asthmatic history. And so we quickly then come up with a diagnosis of an acute asthmatic attack. And that follows then with various treatments, appropriate treatments for this condition. And that's the appropriate approach. This is exactly the kind of approach that we need. In an acute care situation like this, you have to quickly assess and come with a diagnosis and follow up with treatment. There's no time for psychosocial histories and all those kinds of things. Now, maybe at some point in the future, we might want to address that. But when you have a problem staring you straight in the face and needs dealing with, you deal with it right away. It says, for those who can't read it at the bottom line, I'm afraid you've got cows, Mr. Farnsworth. But the problem arises when we're using this acute care model, as I said, to address the chronic long-term health consequence or health issues. And so when we're proceeding quickly to a diagnosis and treatment, what happens then is that the result is a focus on treating each symptom as a separate and distinct disease with a separate and distinct treatment. And so somebody then may come to our office who's got some heartburn, and we'll call that gastroesophageal reflux disease and put them on a proton pump inhibitor. They might have a high cholesterol, and we'll put them on a statin, depression, sadness, and we'll put them on SSRIs, and it goes on like that. And in fact, this is not uncommon that I would see many individuals coming into my practice who are on many of these medications and with these multiple diagnoses. But the problem comes in is that each individual diagnosis becomes a distinct entity onto itself, and the patient's story is never really heard and understood in its full context. And what's missing then is that interlinks between all of these chronic conditions. What are the underlying drivers and factors that are creating this number of chronic diseases in this individual? And in fact, I think it was from Dr. Mark Hyman, who is actually the president of Institute for Functional Medicine, who once said that what distinguishes a holistic doctor is they're seeing patients with a whole list of problems. And the problem then comes from when we're focusing on a particular problem, and maybe we are correcting it really, really well, but if we're not looking at that whole picture, we might in fact see them coming back with yet another problem. And I do understand. I've been in practice for many years, and I understand the demands that are put on healthcare providers with a shortage of healthcare providers, physicians, and the number of patients that even in fact don't have doctors to begin with as well too. And it's really hard to have that time to adequately assess a much broader picture. And I'll speak to that, and it's what our morning speaker talked about, Derek. I mean, this produces already a lot of stress on our healthcare providers. But if we're only addressing one problem, one symptom at a time, and failing to address the bigger picture, we are going to see potential catastrophic outcomes. So the top 10 causes of death in the US in 2011 from the Center for Disease Control stats, we see that virtually all of these could be largely preventable through changes in lifestyle and environmental changes. And one that's not making that list is medical errors, which really ranks at number 3. More than 180,000 people are dying from medical errors. And again, this too will change as we come to understand what is in fact going on, and maybe not having to use the number of treatments that we're using. And maybe the number of drugs will also decrease as well too. And so we have a list of the top 10 drugs used in Saskatchewan, and we see that 7 of these top 10 are used to prevent heart disease. And so we have 3 that are lowering cholesterol and 3 that are lowering blood pressure. Number 8 on the list, rabeprazole, is used to lower stomach acid. And what some of the concerns that I've had, and what I'm seeing now reflected in the peer-reviewed literature as well too, is that in fact we might be using these drugs more often than we may need to be. And in fact, there's even the question is that we're putting on people who don't have a true indication for these drugs. And even those who do have this true indication, profound acid inhibition will never be ideal, because acid secretion isn't the primary underlying factor in this problem to begin with. So questions that aren't being addressed that we need to look at are what causes chronic illness and what's the cure for chronic illness. Now, these are simple and yet complex questions at the same time. And part of the confusion might come from, our seeing humans as complicated systems, when in fact they're complex systems. And there's a world of difference between the two. They're not synonymous. If we take the jet, for instance, it's an example of a complicated system. The steps, there are many steps in its production and function, and they're linear from start to finish. If there's a problem that comes up in terms of its function or structure, those who have that understanding, mechanical engineering, can read the schematics, go in and find where the problem is and fix it. It's predictable. But humans, on the other hand, are anything but linear and predictable. We have feedback loops, redundant pathways, multiple alternative pathways, that can lead to unintended and unexpected outcomes from any types of inputs and interventions. And these can differ quite dramatically from one person to the next, what we call in functional medicine biochemical individuality. And so we have to look beyond just relying on linear treatment thinking and protocols and move beyond the conventional biomedical paradigm to one that would include a systems biology approach, and one that sees people, individuals, as biochemically unique, complex adaptive systems, because that's what we are. And so, for example, this is, get your pens out and jot this all down. This is an example of countless complex pathways in our human body. And this one represents the activation of NF-kappa beta. Now, NF-kappa beta is a transcription factor that is involved powerfully in inflammation and cancer as well too. And so drug companies have been spending countless millions trying to find a drug that can effectively block this activation. And yet either the drugs have failed because of these alternate pathways or because of the drugs being far too toxic to our system. So again, linear thinking doesn't apply here very well. And this again is just one of multiple ones in our body. So we need to shift our focus solely from medicine by symptom, diagnosis and location, to one of cause and mechanism. And so you can have patients who have the same diagnosis, and yet the underlying mechanisms and causes are very different and distinct, and they may very well need different approaches to intervention. We also need to move beyond solely looking at risk factors and downstream consequences to also look at the upstream causes and mechanisms of dysfunction. And we need to look at health and disease as a continuum. It's not like one day I am healthy and the next day I have diabetes or heart disease. It's a progression over a period of time from health to disease. And we want to intervene as early as we can. And we need a new framework to help make sense of this. And so when we're seeing patients in our office, they may very well, we've done a physical examination, we checked their blood pressure, everything seems fine. We've done some blood work, their cholesterol level looks good, their blood sugars are fine, and we say, you're healthy. But in fact, this individual may in fact be really stressed out. They're not getting hardly any sleep. They don't have time to exercise. They're so busy that they can't eat properly. Hey, maybe it sounds like a physician is. But in this situation, then, on the surface they seem well, but they're really not. They're on that progressive pathway towards disease, and so they may not be ill yet, but they certainly have that potential, and that's when we want to intervene much earlier. So building on our conventional medical roadmap, we can expand our framework to include some of the concepts of functional medicine to help us solve this problem of chronic disease. Functional medicine, as Dr. Kalcher said, is personalized, lifestyle-based systems medicine approach that is addressing the underlying causes of chronic disease. So some of these principles I mentioned briefly about biochemical individuality, about how gene expression is influenced by environmental and lifestyle factors. Patient-centered medicine takes on a new meaning when we explore patients' unique responses of their genes to the environment to which they're exposed, the mechanisms of disturbed metabolism of that gene-environment interaction, and how best to intervene. And then we have some of these other principles as well, too. Again, that dynamic balance, that it's never static from being healthy to sick, and these interconnections between one system and another. And so the signs and symptoms, the organ system dysfunction, are the branches of chronic illness. They're the manifestations of each person's or patient's unique physiological biochemical response to their environmental inputs. So these environmental inputs down here, that we've psychosocial and diet and physical exercise and stress and that sort of things, those inputs, uniquely defined by their genetic predisposition. And so these form the roots of the problem. Now, what are the drivers then? The mechanisms, the dysfunctional mechanisms I mentioned. They're in functional medicine. We call them fundamental clinical imbalances, and these become now some of the novel mechanisms of risk factors that are being looked at and explored in chronic illness. And so we're seeing things like inflammation and oxidative stress starting to become more of interest in the literature and research. Things like autonomic dysregulation, endothelial dysfunction, things like leaky gut, GI microbia, the microflora of our gut, is now also becoming very interested in terms of research and its implications in chronic diseases. So chronic illness then results from disturbed metabolism, largely caused by lifestyle and environmental factors affecting gene expression. And again, those factors will be different from person to person. So in functional medicine, the patient's full story becomes of central importance. And so the critical questions become, where do the symptoms come from? In other words, what are the antecedents and triggers? We want to know what's keeping it going. In other words, what are the mediators? And then we also want to know what can be done to change this disease allostatic balance point that the patient seems to be locked into. Or in other words, what are the best points of underlying leverage that we can to help correct this condition? And so this is kind of one of the models we use in functional medicine frameworks that is called the matrix. And so we look at the patient's story here in terms of antecedents, triggers, and mediators, the lifestyle and the other environmental inputs, and then looking at those disturbed mechanisms of imbalance. And this can provide then a better understanding of what's going on and a way to intervene. And now, granted, this is not the kind of thing that you're going to do in a 5 or 10 minute appointment, and yet I will speak to about how we can use some of these tools and what needs to be done to make this a part of our practice as well too. So, in terms of prior to our understanding of the risk factors, our focus as clinicians has been largely on these treatment of these clinical endpoints. Not so much death, but heart attacks and heart failure and strokes and things like that. But over the last number of decades, we have now come to understand these established risk factors, and in terms of their aggressive management, these being dyslipidemia, hypertension, and hyperglycemia. So in terms of this fairly aggressive management, in terms of usually through pharmaceuticals, to prevent these clinical endpoints. And so the assessment of these established risk factors, their treatment and their follow-up have really become the mainstays and the basis of clinical practice, of healthcare policy, of research, of clinical practice guidelines, even healthcare performance evaluation. And while there's been certainly successes with following this this aggressive management, we haven't achieved the desired benefits of preventing these downstream clinical endpoints as much as we had anticipated. And again, that aggressive management is not without causing some harm as well too. And that's in part because we are looking at addressing the downstream consequences of these upstream drivers here. There have been a number of studies that have shown that individuals who have been successfully treated and managed with these established risk factors are still at higher risk of clinical endpoints, heart attacks and strokes, etc., compared to those who don't have these problems even to begin with. And that speaks then to the pleiotropic effects of these higher drivers, the poor nutrition of the stress of physical inactivity and these other lifestyle factors. And as I said, that when we have these multiple pathways, that again, in the complex human beings that we are, we can create novel risk factors like that oxidative stress and endothelial dysfunction and autonomic dysregulation that often don't get addressed and dealt with to that same degree. So the questions we have to look at then are not just how low do we need to get this person's LDL cholesterol or their blood sugar or their blood pressure, but why do they have these elevations to begin with? What's behind these elevations, and in fact, what are the mechanisms by which they're also contributing to clinical endpoints? So how is LDL cholesterol becoming atherogenic? And so studies like the Interheart study that was published in 2004 in The Lancet looked at over 30,000 adults and found that in terms of making substantial lifestyle changes, was able to reduce the risk of heart attacks by 90%. The EPIC study that was published in the Archives of Internal Medicine in 2009 was looking at over 23,000 adults and found that adherence to 4 simple behaviors, one being less than a BMI of less than 30, regular physical activity, not smoking, and a healthy nutrition, which meant increasing your fruits and vegetables, a little less red meat, a little less refined foods. That adherence to 4 of these behaviors was able to reduce the risk of diabetes by 93%, of heart attacks by 81%, of strokes by 50%, and cancer by 36%. So these are huge numbers. And they found that even adherence to one of the 4, still had profound benefits. Adherence to more of them were synergistic and built upon it as well too. And so we have to be looking at helping our patients, and patients themselves have to look at helping themselves to engage in these behavioral changes. So we have to, in fact, we have to rebalance the way that the research is done, that our practices are done in terms of healthcare policy towards addressing these chronic downstream causes or upstream drivers of chronic illness. We have to make the assessment, treatment, and follow-up of poor nutrition, of physical inactivity, of these other lifestyle factors as routine as we do checking a blood pressure or checking somebody's blood sugar. And what can be said about heart disease can be said about virtually every other chronic illness. And where we're intervening with Alzheimer's disease tends to be at the very late stage with our cholinesterase inhibitors, which are frankly been found in most recent research to be of not a lot of use. And they don't prevent the progression to begin with either. And so what we want to do is look at what are the pathways that are leading to brain dysfunction and intervene maybe higher up at these earlier intervention points, maybe cutting out the inflammation, maybe reducing the oxidative stress so we can protect our mitochondria. But even further up then is that what are the various insults that are driving these inflammatory and other novel risk factors, and looking at primary prevention. And so this picture in part captures some of the way that we do medicine. And in fact, I would say that in fact, not just that we do medicine, but the way that society also engages in medicine. Because what we'd see here is that, yes, there would probably be research that would tell us that the best way to deal with this would be mopping up the floor. And so that's what we'd be engaged in. And in fact, more research would come out that would say that, in fact, if you have a brand new mop that absorbs 10 times as much water, it's going to be even better. The only problem with it is really heavy and you're going to strain your back and it might scratch the floor. It has some problems with it. When in fact, there's not enough research and not enough interest in turning off the faucet itself. And that is one of the things that, again, this isn't just, it's not the physician who's going to be turning off that faucet. They are going to be the ones who recognize then where that faucet is and what's driving it. And again, it comes down to each individual to make those decisions and choices to turn that faucet off. Some of the emerging concepts in chronic disease, we talk about the exposome. This is the totality of exposures received by a person during their life, and encompasses all the internal or endogenous and the external, the exogenous factors, intoxicants. And I've got a picture that I'll show that in the next slide. The concept of epigenetics is how gene function expression is affected by environmental inputs. And nutrigenomics is how, in fact, that gene expression is in fact expressed by and affected by nutrients and phytochemicals. And then this is probably an area where we don't have as much, certainly as much research on, and yet is an area I think is really of profound importance, and is probably going to be one area that is going to have most impact on the tsunami of chronic illness, is the Socio Genomics. In other words, how do social networks influence health and disease? So in terms of that exposome, it used to be thought at one time that, whatever genes you were born with, if you're dealt bad genes, you'd probably have a bad outcome. If you had good genes, you're going to do okay. And yet that's really not the case. Studies, over 400 genome-wide association studies and heritability studies have in fact shown that the genome or the genes really only contribute about 10% to the burden of chronic disease. We see that more than 90% is driven by these environmental factors and lifestyle factors. So you have these external factors that can represent things like radiation, pollution, diet, drugs, stress, etc. And you have these internal, endogenous factors, things like xenobiotics and oxidative stress. Again, that mentioned that gut microflora being more and more of an important contributing factor. And these differ from one person to another. Not every two people are going to have those same levels of exogenous and endogenous exposures. And that's certainly one of the things that Sir William Osler knew when he said it's much more important to know what sort of person has a disease, or patient has a disease, than what sort of disease a patient has. And so in nutrigenomics, we want to look at, we want to look beyond thinking of food just as something that fills our belly. We want to understand that food is probably one of the most powerful epigenetic modifiers, for better, for worse. And we want to look at food beyond just as prevention, but it plays a very important role in therapeutics as well, too. So if we look at something as simple as broccoli, we see that this inner ring here represents pathways by which cancer progresses. The ovals and rectangles here are various pharmaceutical drugs, anti-cancer drugs that are impacting generally, one of these pathways. And then the green arrows represent the various points of interaction with broccoli or broccoli bioactives. And so we're seeing that food can act at many multiple pathways. Same can be said of curcumin. A lot of studies showing the benefits of curcumin in a number of human diseases as well, too. And the same could be said for many different foods and herbs and spices. In fact, the most important information that we give our body is at the end of our fork. And I'd say really attention to nutrition is really of critical importance. And Hippocrates knew this when he said, let food be thy medicine, and thy medicine be thy food. And maybe, if we're fortunate, is one day in the future, we'll see pharmacies that are dispensing more than just prescription drugs. And maybe it's coming. I had the pleasure of meeting and talking to Dean Ornish a few years back. He was presenting this at a conference down in the States. The findings of research he had done on intensive nutrition lifestyle interventions on men with early prostate cancer. And what he found was that inside of 3 months, that this adherence to this lifestyle change management was able to affect beneficially 500 different genes, turning on almost 445 genes that were anti-cancer and turning off almost 450 genes that were cancer promoting. And that's in 3 months. Again, you can't get that kind of results with medications, and it did not take an exceedingly long period of time. So once we start to see patients' problems from this expanded idea of underlying mechanisms and upstream causes, we can start to add more things to our therapeutic toolkit. So we're still going to use our drugs in surgery and all those kinds of things. Of course we will. But we can expand to using a number of these other important tools. And we're not going to be experts in all of these as well, too. We're not going to have the time to engage in all of these. And this is where working collaboratively with our healthcare colleagues is going to be of critical importance as well, too. So going forward, we have to ask ourselves, do we have the right scientific framework to educate practitioners, conduct effective research, and diagnose and treat chronic disease? Do we have the right delivery models that address chronic, underlying biological and social causes of chronic disease? So we have to rethink many things that we thought we have taken for granted. And we have to come up with some creative solutions. We have to think beyond the box. As Albert Einstein says, that no problem can be solved from the same level of consciousness that created it. So we can't do the same old, same old. It can't be, yet again, a new medication. We have to look beyond that. And so some of the things that we need to look at engaging in to make this a reality are some of the things that are already happening here in the College of Medicine in terms of curriculum change, helping our students, medical students, and eventually this should really be all healthcare science students to better understand these novel risk factors, these underlying drivers of chronic disease and the mechanisms of chronic disease and how best to intervene, how to work with our patients in terms of behavior change as well too. That's going to be critically important. And I say that is important in terms of all healthcare sciences because again, we're going to be needing to work as a team. And we have to, the message has to be consistent. It has to be the same. We can't have patients hearing one thing from one group and then hearing something from another. And to give you an example, is that for the last year and a half now or so, I've been working at an integrative cancer care center, first in Vancouver and now in Kelowna. And one of the things I hear almost every day in my practice from the patients who are coming in, from the dietitians at the BCCA and sadly even sometimes from the oncologists, are that what you eat has no bearing on your cancer whatsoever. I've had patients tell me that they were told by the nutrition, if you like to eat McDonald's, go eat at McDonald's. And so that really kind of counterintuitive to what the things that we should be telling our patients. And it creates this confusion because now they're thinking, well, they can have as much sugar, as much junk food as they want. It's not going to do them any harm. And yet there's absolutely solid evidence that says that is the case. We need to look at alternative payment plans. As in the Milken Institute said, that we need creative incentives to help physicians look at doing, and healthcare providers look at providing the prevention and early interventions for chronic illness. And that can include financial incentives. We may need to look at alternative payment plans. I think Saskatchewan may very well be the only province that does have a code for treating treating chronic lifestyle issues and interventions. And so again, this should be something though that should be universal. It should be right across the nation. I know in BC, for example, and that's why a center like Inspire Health works. We are government funded, so it is an alternative payment plan. We do have more time then to spend with patients. And we're seeing people coming in because the physicians in practice there do not have billing codes that allow them to spend any length of time with their patients. And so, not surprising, pretty hard to see somebody coming in with a new diagnosis of cancer and try in that 10 or 15 minutes to really adequately deal with what needs to be dealt with. So we have to change the payment plans. We also want to support reimbursement programs or reimbursement and support for group medical approaches and interventions. And again, what I've seen in my short time in Kelowna has been very exciting in that as patients are coming in more and more, they are joining larger and larger groups, and we have these group sessions where I may lead maybe a part of a day intervention with 25 patients, and then they meet separately in terms of support groups for one another, and I think that's really important because that also speaks to that social support and networks. And in fact, we have to take that message to the communities at risk and at their level. And I'm just going to quickly, the last couple of minutes, 2-3 minutes here, just talk about some of the importance of those interventions, social interventions. So this is a study that had over they were Australian Aborigines that were overweight. They had diabetes. They had basically all the risk factors for metabolic syndrome or heart disease, and they agreed to return to their traditional hunter-gatherer traditional styles for 7 weeks. And at the end of 7 weeks, what they found was amazing. All of the weight now came in from overweight. They were now at normal weight, and all of their metabolic risk factors significantly improved. And again, it's not to the point I'm saying is that everybody with chronic disease we should dump in the Australian outback. But what it speaks to is the fact that this happened in 7 weeks. It wasn't 7 months. It wasn't 7 years. It was very dramatic, and it was not with the introduction of anything new as well too. And there are a number of studies that show, and sadly though, there's too few of these, but showing some of the effects of interventions at the community level. Community gardens, they showed that in individuals, that even one person was involved in a community garden, that everybody in that family ate more vegetables and fruits every day. And we see that with weight loss programs at community centers, and the idea of shared medical visits as well too. So again, meeting people at their level is going to be very important, and engaging that social networking. This was a very interesting program that was actually initiated by Pastor Rick Warren here. He's a pastor of a mega church in Southern California, boasts of over 30,000 congregants, and he was noticing that many of his congregants were very overweight and were in quite poor health. In fact, he included himself in that as well too. And he thought, we need to do something. So he engaged 3 other doctors to come up with a healthcare initiative that was delivered over 2 days, and it included didactic lectures and some hands-on experiential kind of work, things like cooking classes and that type of stuff. And they expected maybe 2,000 people to show up, and over 15,000 people came out. And after that initial kind of 2-day program, then they worked together in small groups. Again, the physicians no longer had any role in this, but they met together now in these small groups. And what they found was at the end of 6 months, they had a combined weight loss of over 260,000 pounds. It's phenomenal, and many of them said that they were able to discontinue or dramatically reduce the medications that they were taking. They felt better, more energy. Everything seemed to be better, they said, in their life. And so it really speaks to the power of this intervention at the community level. What also was of interest was that those who were working together in groups lost twice as much weight as those who were working, doing it on their own. So it speaks to the African proverb: if you want to travel fast, go alone. If you want to travel far, travel together. And I think we do a lot of traveling fast and alone. And I think it's time where we start to refocus and think about how we can slow things down a little bit and provide a bit more support. I think we'll go a lot further that way. Thank you very much. So questions?
Yeah, Joe, I'd like to open up the floor for any questions for Joe Schnurr. Just please come to the mic. It might be a little tough to hear, but.
This was very interesting. It's not really a question, but from my days in medical school, we had a gastroenterologist who taught me basically to tell patients, in a sense, if you want to lose weight, develop 2 instincts, basic instincts. First one, remember? Survival. I don't want diabetes, I don't want heart attack, I don't want stroke. And he implored us to think what the second basic instinct to tell your patients to lose weight. Any ideas? Vanity.
Thank you for the comment.
Hi. I realize the importance of food and that in prevention and that. Would you say a few things about organic, non-organic, and that area?
So the question is about organic and non-organic foods. There's been a lot of controversy, confusion. Are organics any better for us or not? I mean, I think that there's certainly part of the way that we do research, sadly, creates confusion over a great many things. Sometimes it may be intentional confusion. But having said that, is that certainly organic foods do have higher levels of the polyphenols, and these are the ones that are the antioxidants. They have the number of the anti-cancer and anti-inflammatory, antioxidative stress kind of effects that we want to have. They tend to be cleaner in most cases, and not infrequently, if they're picked organic, usually the soil in which it grows is going to be certainly much healthier, and so other nutrient riches as well too. So in terms of organic versus non-organic or inorganic, I would in most cases I would encourage that. If though, for certain such circumstances, I mean, certain foods in this dirty dozen list. We go to www.ewg.org, Environmental Working Group. They have a list of the pesticide residue on fruits and vegetables, and they rank them from number 1 to whatever I think is 150. So the top 12, what they call the dirty dozen, the bottom of the clean 15, and then anything in between are generally sort of somewhere indeterminate. Now, I would say for the most part, I wouldn't worry about those foods that aren't on that dirty dozen list. I'm going to put my, I'm going to put my money to use. I'm going to put it and save it where it's most appropriate. And so I've seen people buy organic avocados, and yet, our avocados are on that clean 15 list. They're not generally much in the way of any kind of sprays and pesticides with it. So again, people sort of then take it to extreme. But some of these do have high levels of pesticide, and there have been studies that show that yes, they meet requirements in terms of with each amount that's there isn't in a harmful level. But what they don't talk about is bioaccumulation, and over a long period of time, these do bioaccumulate. And there have been studies that show that kids who eat a lot of these kind of things like apples and other things that are fairly high on that list do actually now have higher than acceptable levels in their tissues. So we do want to be careful about some of that. Now, if it comes down to it, if I'm going to buy organic apple from New Zealand or a local apple, from a fruit vendor, farmer's market, I'm going to go local all the time. I want to support the local economy. Generally, if it's going to be from a local food market, they're probably, again, a little more, I'm going to meet the person who's growing it, as opposed to, something that's picked, even if it's organic, but shipped, the world around. And so it also comes down to, food safety and also in terms of environmental safety. So all the things that are going into bringing that apple, that organic apple, to me here, I think I'm going to go with the non-organic.
Joe, your metaphor with the overspilling taps and sinks and mopping up the floor, my question relates to the water plant rather than the taps. So it's around the question of the political economy of health. Mm-hmm. With my particular bias, I always find it a strange relationship with Cameco Corporation and the School of Medicine. And you can think of things like the fast food restaurants and so on and so forth that you've been talking about. But in terms of the corporate level and what they do in terms of providing the environment from which these issues have arisen of chronic illness, and what is the role? I mean, I can think of people like Dale Dewar and Physicians for Nuclear Responsibility is one example. But overall, are you still in the fix-it level, or what about the water plant? That's the question.
Well, that's again a very good point, because I think that as physicians, again, too, one of the things that we have to be as advocates for patient wellness, and that means taking it to that next level as well too. A very interesting story. I listened to a speaker a few months ago in Kelowna, who a physician in New Brunswick, I believe it was, who started to see, she was a dermatologist, started to see a lot of kind of dermatological conditions and other health-related issues, and she thought it was related to the broad use of pesticide use on the lawns and gardens in the community. And she did her own kind of research, correlated this all, did great work on this, and was able to taking it to town councils, kept getting voted down. No, they like their pesticides, they like their green lawns and all this kind of stuff. But she was persistent, and every council meeting she was at, and on and on and on. And eventually, the town elected to listen to her, look at that, and they did put a ban on the pesticide company, or on the pesticide use. Now, interestingly enough, the pesticide company sued the town, and we're going to take them to court. Fortunately, and then that went on for a long period of time. Eventually, in this case, the pesticide company lost. But again, it's this kind of thing, is that it's a huge task, and it is one that I agree is that part of our jobs as healthcare advocates is to also take it up the level as well too. Thank you.
We have time for one more question.
I have two questions, if that's okay. The first one is, how do we get doctors to treat us holistically when they have a sign in their office that says no more than 2 complaints per visit? And the other thing is, how can a holistic approach compete with pharmaceutical companies who get most of the research money that is even collected publicly, because they're the only ones who will do research, and they have a vested interest to keep it as a drug-based treatment program. Like, how can we fight that?
Well, those are both very, very good questions, and I'm not sure if I can adequately answer them either. But addressing the second one first, about the pharmaceutical versus the holistic approach, is that, again, as we start to see more studies that are coming out about the impact of these quick changes, the rapid changes without using pharmaceuticals, and seeing that people embracing that healthy lifestyle changes can, in fact, be much healthier without. And that's going to start to spread. I mean, you get one individual who starts to see the benefit of this, and they're going to talk to another one, and it's going to be slow, but we're going to see those changes. And in fact, that's exactly what we're seeing in Inspire Health. We've opened up this integrative cancer clinic, and initially, even though, for a very small fee they can join and get as much time with a physician as they need over extended visits, we had very hard time for people coming. And I think it's because they were really locked into this, well, I'm going to, you know, use the drug therapy. And again, by no means we're advocating people, you know, stop their chemotherapy. I mean, this is patient empowerment. They do what they need to do, and there is good evidence for, you know, for some of these chemotherapy agents as well too. However, having said that though, is that people just didn't know what they were capable of, and once they started coming, and more have joined the Inspire Health ranks, they're taking that message because they feel so much better and they feel empowered, and they're taking that message to others in their community. And now we're starting to see more and more people coming in. Very hard though, you know, to do a mail out and say, hey, you know, we're open for business, come in. Is changing behaviors on all parts. And the first one was how to find a holistic doctor practicing like that. Again, as things stand in terms of the way practice is set up, that's going to be very hard to see those changes. There need to be changes at a much higher level as well too. You know, in terms of these alternate payment plans and other things that are going to show how important these are, and even educational changes that doctors are going to say, you know, this is really important, and I'm going to want to engage in this with my patients, and I'm going to advocate for this in terms of on behalf of my patients and at the healthcare policy and research and government levels and things like that. So we'll see some changes hopefully coming down. In fact, interestingly enough, I had a patient just before I left here who saw a neurologist in Penticton for her migraines. And she came back and told me that her neurologist said, well, you know, you could take a triptan, but, you know, why don't you go on some magnesium and some butterbur, maybe some coenzyme Q10 first for a while and see if that helps any. I'm thinking, wow, that's a change. But he was a young neurologist, and so maybe we're starting to see some of this curriculum changes kind of filtering through, and hopefully.
One last question.
Thank you for letting me ask the question. I am here to ask you if there is any relationship between chronic illnesses and depression. Are there some common pathways which we really need to take into account when we are dealing with chronic illnesses?
Yes, there certainly are. Again, some of these, what we're now discovering is these, you know, novel risk factors, autonomic dysregulation, hormonal imbalance. So you get changes in things like serotonin levels and other neurotransmitters that can promote things like depression as well too. And then there are a host of other underlying factors. But again, when I see somebody with depression, I don't see them as that this person has depression the same as this person, this person, this person. They're going to bring in all those things that I've mentioned in that exposome, you know, internal, external factors that are coming into this. And we have to assess that and find out what will be the best intervention for that individual.
Joe, on behalf of Betty Ann and Wade Heggie, and I know what Wade's golf game is like, but we'd like to thank you for spending the time with us. It was an excellent lecture, and